You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from benchside to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, and today we are joined by ONS member George Ebanks, medical oncology nurse in the cutaneous oncology program at Moffitt Cancer Center in Tampa, Florida, and member of the ONS Greater Tampa Chapter, to discuss skin toxicities. George was also on the panel that developed the ONS Guidelines for skin toxicities, which published in September 2020. Thanks for joining me today, George.
Good morning, Stephanie. Thank you for having me.
So, the ONS guideline interventions were compared to usual care. Can you describe usual skin care for patients at risk for skin toxicities?
That's a really great question because I specialize in cutaneous oncology with skin cancers. Standard recommendations that everybody should be receiving is they should be using a sunscreen of SPF 30 or higher on a daily basis, and they should be wearing protective clothing. I'm based here in Florida, so obviously, skincare is very important. But also people in cooler climates that are actually more elevated, like in Utah, they also need to be aware of this too. Gentle soaps and moisturizers, those types of things would be standard skincare. Compared to skincare for patients at risk for skin toxicities, we're going to re-emphasize these basics to them before they start their treatment.
Great. I'm sure being in Florida, this is something that you have to work with your patients on regularly. So, when patients are receiving anti-neoplastic therapy and you are doing some teaching with them, why should nurses be concerned about, what these additional skin toxicities may be?
So, nurses should be concerned about these skin toxicities related to anti-neoplastic therapy because, for a certain number of reasons, they can either be dose limiting for the patient because they impact their quality of life. Some of the skin toxicities we're going to talk about actually could put a patient at risk for an opportunistic infection. And if they're on a chemotherapy regimen that can make them neutropenic, what could be a mild infection could easily turn into a life-threatening infection if they're on a chemotherapy regimen that is also at high risk for putting them into neutropenia.
So you mentioned what the additional risks are for patients, when they do present with some of these skin toxicities. One of them is, or actually there's a difference here, but can you describe hand and foot skin reactions and hand and foot syndrome?
This is such a great question, Stephanie, and I'm so happy that we're actually covering this because this is commonly grouped together among clinicians. And when I use the word clinicians, I'm referring to providers and nurses. And this was something that actually really came to light when I was working with the panel on these guidelines. So it is very important that we make the distinction between hand-foot skin reaction versus hand-foot syndrome. So, hand foot syndrome, I think, is what a lot more people think about, which is also called palmar plantar erythrodysesthesia, or PPE for short. But in this day of COVID, where we're all using PPE, I wanted to spell that out for everybody. That is associated with chemotherapy agents such as 5-FU and capecitabine. So, hand foot syndrome presents with diffuse painful edema and redness of the palms of the hands and soles of the feet. This can be very impactful on a patient's quality of life. I had a patient that literally was unable to walk because it was so severe for them. And they were even experiencing pain with these really soft knitted slippers, and when they came into the clinic, they were basically wheelchair bound and couldn't move. So this is really important for us to address as nurses, and especially in our teaching. to be very proactive with patients that are at risk for this. Hand-foot skin reaction is a little bit different. It's actually dose dependent and localized to areas of pressure or friction on the skin, such as heels, the head of the toes, and areas where friction can be caused by shoes or manual labor. And these lesions are sharply demarcated, erythematous, edematous, and painful, and can actually turn into blisters. So it's really important that we recognize the distinction between the two.
You're talking about the how they look clinically, those differences. What are the treatments associated with these?
So, hand foot syndrome is going to be more related to chemotherapy agents like 5-FU and capecitabine, where hand foot skin reaction is going to be more related to multi-kinase inhibitors like imatinib, dasatinib, pazopanib. That's where you will see most of those. I'd also like to add that, what's actually interesting about this when I first mentioned that clinicians tend to group this together. If you look at the CTCAE, which is the grading of adverse events, there is no specific grading for hand foot skin reaction, but clinicians tend to use the grading for hand foot syndrome to grade hand foot skin reaction.
Hmm, that's very interesting. Do you think that that might be something that will change in the future and having a new grading or differentiating, I should say, between the two?
I think with guidelines evolving as they do, especially as we move into a new era of cancer care where we're using a lot of immunotherapies now frontline in certain cancers, or immunotherapies that are second line, and these oral agents, I think we probably will eventually see a differentiation in grading and more guidelines as to how providers and nurses can either preemptively help these patients proactively to limit how severe these reactions happen to them and could cause them to have treatment interruptions or avoid dose reductions that may not be quite as effective in fighting their cancer.
Great. How do the skin toxicities and treating them differ based on the treatments that cause them?
This is such a great question, Stephanie, and thank you so much for asking it. So, I think we need to kind of back up to starting with the nursing process, right? If you think about all of our nursing process starts with assessment, which is going to include, patient history, what treatment they're on, those types of things. That's really going to help us when we're talking about these skin toxicities, how they differ based on cancer treatments that cause them. A really good instance of this is, so if a patient is on an EGFR inhibitor like cetuximab, their skin toxicity is a acneiform rash, which basically looks like the patient is erupting into pimples back from their adolescent years. This would actually be treated very differently from, say, an immunotherapy induced rash. So, with acneiform rashes, we want to be proactive. And that actually goes back to our first question about, being proactive, educating these patients going into their therapy about, using sunscreen, wearing protective clothing, using moisturizers, mild soaps that don't have fragrances, those types of things. When they run into an acneiform rash, we need to make sure that we are proactively educating them to not treat them as if they're having acne, because if they start using like benzoyl peroxide or any of those over-the-counter acne remedies, they're actually going to worsen this reaction, because this reaction is from their skin actually drying out. So they're going to have to step up their moisturizing regimen. They're going to have to step up, how many times a day they're applying their sunscreen to try to keep this acneiform rash to a tolerable and manageable level. And this actually touches base on what I mentioned in our second question. So if we do not control this acneiform rash, it can actually lead to the patient actually getting a opportunistic infection in these lesions. So it's very important that we address that the proper way. There's a lot of debate going on right now with the EGFR inhibitors as to whether we should proactively prescribe antibiotics. And there are two choices that clinicians can make to either do a topical steroid to reduce the rash or a topical antibiotic. And that's going to change from practice to practice and provider to provider, as well as if they're going to be proactive or reactive. There's some mixed data that we covered in our panel, whether clinicians should be proactively prescribing the doxycycline would be the antibiotic, the oral antibiotic of choice, and either a topical steroid or a topical antibiotic. I've seen over the years that I've been doing this that a lot of clinicians have moved to reactively prescribing this and waiting for the acneiform rash to show up before they prescribe it. And I think that that is tied to this big movement of antibiotic stewardship that we are in right now, where people are not wanting to prescribe antibiotics and set patients up for antibiotic resistant infections. So, and that leads me to, immunotherapy related rashes, which are managed completely differently. So we would start off with recommending, moisturizers. If it's an itchy rash, they can do topical Benadryl, topical hydrocortisone to calm the itching. I've had patients that have to take an antihistamine. They'll prefer to use Zyrtec or Allegra during the daytime hours because it doesn't make them drowsy. They might use diphenhydramine at bedtime to help them sleep. And if these over-the-counter remedies aren't helping them to reduce their symptoms, then they are educated to call us at the clinic so we can prescribe a topical steroid to help calm the itching down. And again, it's very nurse sensitive that we are proactively educating these patients so they don't wait for these symptoms to escalate, because I actually have patients. Unfortunately, in the past, I had one that actually progressed to Stevens-Johnson syndrome and ended up in the burn unit at our Trauma 1 center here in the Tampa Bay area.
Wow, that just shows how important it is that we as nurses are so aware of the side effects that come with the treatments that we are administering to our patients and know how to educate them and really know the questions to ask them when they are receiving treatment to make sure that we're, keeping on top of that and keeping them having as, the best options and experience that they can during, their treatment and that their side effects are kept under control. Are there any considerations that nurses should take in the difference between treating for the hand-foot syndrome versus the hand-foot skin reactions?
Absolutely. So, this is actually another point of debate that's happening right now. I think in different facilities, in nursing considerations, and we do cover this in the guidelines and the pros and cons of it. So, when we talk about the hand foot skin reactions, these are mainly going to be linked to IV infusion chemotherapies like 5-FU, taxanes are pretty well linked to this. And so some of the practice recommendations have been, and I've done this in my time when I actually worked in the infusion area. What we would do is we would do, ice packs on their hands and feet. And the key part of this is that it's during the infusion. So let's say you have a patient that is on gemcitabine and docetaxel for their chemotherapy regimen. You wouldn't be applying the ice packs to the hands and feet during the gemcitabine infusion. You would be applying the ice packs to the hands and feet during the docetaxel infusion. And basically what you're doing is you're wanting those capillaries to constrict to reduce the severity of the hand-foot skin reaction that the patient can run into. This is going to be very different from patients that are at risk for hand-foot syndrome because a lot of those agents tend to be oral. I would highly recommend for nurses out there, depending on the facility you're in and how your clinic or facility is run, definitely make a concerted effort to find out who your rep is. I'm going to use it is imatinib Gleevec, which has been around a long time, and it was originally done for hematological malignancies. And when I worked in sarcoma, it was one of the first line treatments for patients that had GIST, which is a gastrointestinal sarcoma. And a lot of those drugs will actually, if you can reach your drug representative for that company, they can actually supply you skincare kits that you can proactively give your patient, when you're educating them, with moisturizers. Some of the kits actually have sunscreen in them, which is not really a big thing that you're thinking about with the palms and the soles of the feet. But some of the kits would have, mittens and socks for patients to protect their feet. So to just try to reduce that hand-foot syndrome that they can get. Because like I said earlier, I had a patient that it was so bad that even these very soft hand-sewn slippers that they were wearing, they were still stuck in the wheelchair because it was just so painful for them, coming in to see us, which is obviously a necessary part of their care. And then the provider has to, look at the extent of the side effect that they're having. And a lot of those oral drugs have an algorithm that comes with them to talk about basically like drug holidays or medication breaks to help the symptoms subside. And then when you restart those treatments, there's an algorithm of how to lower the dose. And then it becomes a situation where you're trying to balance this quality of life impacting toxicity for these patients, right? Because we're here to not do harm, we're here to help. So then you really get into this balancing act of, can we give them the most effective dose for their cancer and reduce these, toxicities can really impact their quality of life.
Right, that is so important because, if we're not paying attention to those things and they are not experiencing a good quality of life and really not tolerating that well, then, how many patients, are we going to see that are going to stop treatment because they just absolutely cannot tolerate that. So it is so important. What are some misconceptions patients have about skin toxicities?
Stephanie, that is probably the best question that you can ask because I've been doing this for quite a while. And I think that as nurses, when we're educating our patients on these skin toxicities, I think it's really important for us to emphasize to these patients how severe they can actually be. And I think one thing that I found that has really helped me with educating my patients is if I remind them that our skin is actually our largest organ, and you would be surprised how many people do not think of our skin as an organ. So when I start my conversation with my patients this way, and I remind them, we talk about all these toxicities and, potential organ damage, like let's say in melanoma, right, we use BRAF and MEK inhibitors. So it's really easy to get lost in talking about, the cardiotoxicities that can happen from the MEK inhibitors, those types of things. But we really need to emphasize the skin toxicities as well and remind these patients that the skin is their, number one, their largest organ. Number two, it's actually, and I don't know that that's truly number two, but it's actually their first line of defense from other types of harms that can happen to their body. Our skin protects us from infections. It helps excrete waste from our body. So I think just starting with that basic education to our patients before we launch into teaching about skin toxicities really helps patients to understand how managing these skin toxicities is really important and how it can impact their quality of life, how it can impact their treatment. So I had a patient that was on, the BRAF MEK inhibitor because I work with a lot of melanoma patients. And this is something also to be aware of as nurses, is there's no true indicator for us as nurses or even providers that tells us who is at higher risk for these skin toxicities. Especially when we talk about skin toxicities like photosensitivity, which is very common on BRAF inhibitors. So an example I'd like to use is this particular patient I'm thinking of was not fair skinned, was not blonde and blue eyed, right? This patient in particular actually had native Indian heritage and brunette, already had a baseline tan, and literally would drive from a neighboring county to come see us at the clinic for their checkup. And despite using SPF 50 on their skin driving here, they would actually still get a sunburn on their driver's window side arm that was exposed to the sun through the window glass. They would still have a sunburn by the time they came into the clinic. So I think we can avoid a lot of patient misconceptions about these skin toxicities and how harmful they can actually be if we really just start with the basics for our patients and educating them, the importance of what our skin plays for our overall health.
Thank you. That does just show the importance of our education to the patients, but our education to ourselves as well. And I think, as you were talking about all of the immune therapies, there are so many new medications coming out and so quickly that we just don't know what all of their side effects might be, yet that, this is just such an important thing for us to be aware of and to know. So let's move on to another recommendation that the guideline panel gave, and that was recommending cooling systems and cooling caps. What are the clinical requirements needed to set up a cooling system program?
So this is going to vary from facility to facility, and you tend to see the scalp cooling mainly with breast cancer patients. So some of the limitations that we can run into are, is the infusion center set up to accommodate these scalp cooling therapies that we can use? So one instance is when Moffitt decided to build the McKinley satellite that I work at right now, and they moved the breast cancer clinic over to that facility. They actually had this in mind when they built the infusion center for our breast cancer patients that would be treated in this satellite. So they made sure that when they set up the infusion center that they did leave space to actually acquire a professional scalp cooling system that the patients may opt to use. So that really runs into if you have, older facilities that don't have the space required for these systems, because they're not just like a little purse size thing. They're actually pretty big. So I think you see it more in older facilities that before this technology became widely available, their infusion centers aren't set up to accommodate this. And the scalp cooling technology is actually used again while the patient is actually receiving the IV chemotherapeutic agents. And it's actually kind of, when you take a look at it from the patient side, whether the facility provides the scalp cooling technology or if the patient is going to a facility where they don't provide it, which I've also seen, there's also a burden on the patient. For instance, if the patient is in a facility where they don't have the system set up in place, and this is something that the patient wants to pursue because they've heard of it, they have to go and they have to find the manufacturer, which, hopefully as nurses, if we're in that situation, we can give them the resources to make this part of their treatment journey a little bit easier instead of them having to Google, ended up on the, blogosphere with misinformation. So, and I actually did take care of a patient a few years ago that went through this as the technology was coming out. And it was a big burden on the patient because they had to buy the scalp cooling cap, they had to go buy the dry ice, they had to make sure that every time that they went in for their chemotherapy treatment that they had a buddy with them, because they literally had to be prepared to change out the cooling scalp every 20 minutes during the infusion and do it like clockwork. And then they actually have to wear it for a certain amount of time after the infusion is done to try to reduce the alopecia that comes from these chemotherapy treatments. So hopefully, as we move into a new era and, facilities are starting to, either expand their infusion centers or build new infusion centers, satellites, if they're expanding in their region, they take these into consideration when they're building their infusion centers so that these patients have the option. And it will really help decrease the burden on the patient because they're obviously already going through enough as it is with the cancer diagnosis, any potential side effects that their actual cancer is causing them, much less any potential side effects that the treatment that we're giving to them could also bring along for them.
Very interesting. Thank you. What are some common integrative health approaches to treating skin toxicities, and what do we need to be aware of before recommending those to our patients? Because we know that they're hearing from all of their well intentioned family members, all of the home remedies and different things like that that they should be doing or that they could do to help out. So, what are some of the things that we as nurses could do and need to be aware of?
So this is a really challenging question and topic because, you know, herbal supplements that are on the market, there's always new ones coming out that are being hyped. The data is always changing because a lot of the data that comes out is actually coming from the manufacturer of these herbal supplements or topicals, and they're not actually FDA approved. So there's no mechanism in force to make sure that, you know the strength is truly what the company says that it is, right? So let's take for instance CBD, which is, a huge thing right now that's being really hyped up with all of its, benefits, right? So I feel like it's so anecdotal, but it's so important for us as nurses. One of the things I do is when a patient comes to me and says, "Hey, I'm thinking about using this, George. What do you think?" If I have any doubt in my mind that this could potentially be something that would interfere with the effectiveness of their treatment, or it could potentially actually exacerbate a toxicity they could run into, I always, always, always go to our clinical pharmacist that is readily available to us and is always willing to help to run it by them. And they look and see if they can find any data. And again, a lot of this data tends to come from the manufacturers. And then you have a lot of anecdotal data. So, with CBD oil, this patient swore that it really worked for they had a melanoma mass that was, quite visible and very painful. It would get inflamed from the treatment that we were using, and they swore that it helped them, with the pain that would actually happen in their tumor. But again, that's very anecdotal, and so I will have patients that they want to try CBD oil before our standard recommendation of, using, hydrocortisone for their immune mediated rash. And it's just something that we just have to be really aware of and try to establish that very open dialogue with our patients so they feel they can trust us if they're thinking about using any of these, alternative medicines type of thing, that they can come to us and say, "Hey, I was reading up on this. What do you think about this?" And that reminds me of when I worked in radiation. Actually, ONS came out with the publication where they were recommending calendula lotion. Instead of, if you've ever worked in radiation, a lot of radiation facilities just hold on to this use of aquaphor that's been forever and ever and ever and ever and ever. And I thought it was a really interesting study that ONS published about the calendula lotion could actually be a more effective remedy for the dermatitis that can come from radiation therapy. So I think to sum up my answer to this question is just as nurses, we really need to work on making sure that our patients trust us to have an open dialogue, that they can come to us if they're thinking about using any of these things. I think it is also really important as nurses that we try to educate ourselves as much as possible of some of the alternatives that patients will go seeking, because a lot of patients will try to do some other alternative other than a standard medication because they feel like, I'm already on this cancer medication. And if you have an older cancer patient, they might be on medications for hypertension and other stuff like that. And they don't want to add one more medication to their list. So they're going to go and they're going to try to find, an alternative integrative approach that could be, CBD oil or something like that.
That is really true. I think it's so important that we have that trust with our patients. And even with the studies saying that we are the most trusted profession, I think it's important that it's beyond that and that they do trust that they can come to us with, those kinds of things and talking about what they're on or what they're thinking about, and that it's not going to be a punitive or that they're going to get in trouble if they're asking us this or if they happen to try something, and then come and tell us, but really having that open conversation. What's something about skin toxicities that's not often discussed, but you wish people knew more about?
Something that I feel that's not often discussed is with these skin toxicities, like really how harmful they can be to these patients. And I think why it's not openly discussed is because we're already throwing so much information at these patients about, their treatment regimen. They may also be, hearing about their prognosis for the first time, that they're stage 4, what those statistics are. And I think sometimes we tend to hedge a little bit of the truth. And I hope that as we move forward in cancer care that we learn as providers, and when I say providers, nurses are healthcare providers, even though we don't prescribe, but also, the medical oncologists, the APPs. I hope that we come into an era where we can be a little bit more open with our patients about how fatal some of these skin reactions can be, and how they really do need to alert us at the first sign of something happening so that we can step in, which, I brought up my patient earlier that actually ended up in the burn unit at our Trauma One center here in the Tampa Bay area, because I don't think that people understand that these skin toxicities can actually very quickly snowball into a potentially fatal situation, something like Steven Johnson syndrome. And I think the reason why we tend to hedge those pieces of information to people is we don't want to scare them even further, right? But I feel like over my career, I've kind of learned to balance some of those stark truths. And it may sound flippant, and I hope it doesn't, but I always kind of, when I see that deer in the headlights look coming from my patients, I always try to add a little bit of humor and levity to the situation, and, say, hey, if you actually go home and read your Tylenol bottle, there's a lot of really bad stuff that can happen from that too. So just because I'm telling you that, the immunotherapy treatment that we're giving you has like even just a 1% chance of you having Steven Johnson syndrome and ending up in the burn unit, I'm saying that to help protect you. I'm not saying that to, scare you, or, I want the best treatment for my patient, but I also want them to be well educated enough to know that, hey, I really need to trust my nurse and say, hey, something's really wrong here, because I don't think any of us nurses want to learn that our patient didn't trust us to come to us and say, hey, something's really wrong here. I can't, like, let's go back to the hand-foot syndrome, that they don't come to us and say, hey, you know what, I barely can walk right now. Like, this hurts so much. Because another part of that is that patients, if you've been doing this long enough, I'm sure that you've run into a patient that is terrified of coming to you and saying, hey, I'm really running into this problem, because they're so worried that you're going to go back and tell their medical oncologist what's happening with them, and the medical oncologist is going to stop their treatment. And I think that that goes into a lot of the patient's psyche of why it's not that they don't trust us. They're just so, they know for a lot of them that this cancer treatment is what's going to save their life. And I think that just creates this background fear for them, that it's not that they can't trust us with that information, but they're terrified of telling us that information and what it might mean for their treatment journey. So I really hope that we're able to have more open discussions like this with our patients, because it really just benefits them in the long run.
Right. I think that's a very good point, is that, you almost have those two extremes where we were talking about it's so important that we are aware of what these side effects and issues are, because we don't want the patients to get to the point where, they are so uncomfortable that they, don't want to, their quality of life is so poor that they don't want to go on with treatment, to the other extreme where patients are not telling us what's going on because of their fear of having to stop treatment, because they feel like they let it get so bad that now they're going to have to stop treatment, and that would be the worst thing for them. They just want to keep going. So it is a balancing act. I think you're right in how, to get them to understand it and to trust us with that information that they have, and, how they're feeling and how they're tolerating their treatments and things. So, in addition to the ONS guidelines on skin toxicities, what are some other resources that you would recommend for oncology nurses to really be aware of this side effect management that is out there, with patients?
Well, I think probably our number one resource that a lot of nurses can tap into is just to educate ourselves by going to the NCCN criteria of grading these toxicities. When I worked in radiation, what was really nice was the platform that we used actually built in the CTCAEs into the EMR. So when you were having your visit with the patient, you could actually like click on that particular toxicity and it would grade it for you, which was really a helpful tool in helping to develop, how do we continue treatment with this patient? What interventions can we use to make this toxicity a little bit more manageable? So I think the number one step is, let's educate ourselves on the NCCN grading criteria of these adverse events. And that's easily accessible. You just go online and type in nccn.org. And they actually have a patient-friendly version of that, too, if you ever want to point that out to your patients, that it breaks it down into very simple terms for them. But ONS has so many other resources. And actually, getting invited to this panel all started with me sending them a simple question. And I actually don't remember what that question was, because this is going on over a year ago. And then suddenly I was invited to be part of this amazing panel in this amazing project, which I think is really going to benefit our patients, our nurses. And so to me, ONS is always like the number one resource. But I think the other resource that every nurse should tap into, aside from ONS, is to go and educate ourselves with those NCCN guidelines that are updated. They're online, they're easy access for us to get to. Again, you can provide your patients with the patient-friendly version of that, which doesn't use all the medical lingo that we use, and it keeps it very patient-friendly and helps them understand, some of the recommendations that we're making and why we're making those recommendations to them. Because I think it helps them also gain that sense of trust that we're not just making this up. These are actually like national guidelines. And when we say, well, this is a really gray area for us to discuss, and I'm going to do my best to give you the answer, that also creates trust in the patient. Because if you're willing to be honest and say, there's no certain benefit to what we're talking about here, like let's say the CBD oil, and you have a national professional resource to point them to, that just also builds that trust between you and that patient that, hey, George isn't just making this up, or at least George was, honest enough to say, there's not really any clear benefit to this, but it could harm me. And now I'm looking at this in the national guidelines. And I just feel like, at least in my career and in my experience, I found that helps build trust between me and my patients, that, sometimes they tell me everything, and me and my colleagues get a kick out of that. But it's actually, a major compliment, really, that my patients want me to know that these things are happening because they have that trust. And I think that, all nurses should work to gain that trust with their patient.
Well, George, thank you so much for everything that you've talked to us about today and for your work on the guidelines panel. I'm sure you may have sent that question that you had through the ONS communities. And I think that's another area that, where when people do have questions, it's a good place to put those questions out there and find out what other people are doing. And also to get, feedback from the nurses on staff at ONS and, helping direct people towards things like the ONS guidelines on different toxicities and the management of those. So as we finish up, do you have any final comments about skin toxicities that you'd like to share with us today?
I think that there's a lot more that we could talk about skin toxicities, since I actually work in a skin cancer program. But I think that we really covered quite a lot. I'm always happy to be a resource and help answer any questions that might come up. But I think we did a great job of covering quite a few of the more common skin toxicities that we run into. I guess my closing comment would just be, as nurses, make sure you understand the treatment that the patient's on, because that really is going to dictate, what type of skin toxicity they can run into if a skin toxicity is part of their profile. And just being, making sure that we're really well educated on the proper interventions, because again, just going back to the EGFR inhibitors, it's very important that the nurse and the patient understands that, yes, it looks like pimples, but we're not going to treat this like pimples, because treating it incorrectly is actually going to make the situation worse for the patient. So I think that would be my final comment, is just, as nurses, let's make sure that we're doing everything in our power to educate ourselves on the type of treatment that our patient is receiving. If a skin toxicity is in the profile of that treatment, that we're educated on what that skin toxicity looks like when it presents itself, what's the proper management of it, so that way we can do the most benefit for our patients and help them tolerate their treatments.
Thank you, George.
Thank you for having me, Stephanie.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you download your podcasts. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org.